So today we have 480,000 working poor people. These are working age adults, and they have been afforded an opportunity for health care coverage through the Medicaid expansion. It's been good for them because now, rather than having to wait at home until they get so sick that they have to go to an emergency room, they actually have access to preventative care, primary care. And so they are being diagnosed, for example, with these diseases much earlier in the process than would otherwise have been the case, while they can still be treated effectively, and by the way, treated in a cost-effective manner too. And so the uninsured rate in Louisiana went from about 1 in 4 in this population when I became governor to much closer to 1 in 10 today, the lowest it has ever been. And on top of saving people's lives and improving people's lives, which is the most important thing, we've actually saved money because of the enhanced federal match rate by simply bringing our tax dollars back from Washington to Louisiana to provide health care coverage for our working poor people rather than those dollars going to the other 30 states that had expanded Medicaid. We are saving money. In fact, we've saved over $300 million state general fund since the Medicaid expansion went into effect on July 1st, 2016. It's simple math. If someone's uninsured and they go to the hospital, we pay 40 cents on the dollar for their care. But we can insure them for no more than 10 cents on the dollar through Medicaid expansion. And the 10 cents comes from a statutory dedication, money we wouldn't have but for the fact that we expanded Medicaid. The 40 cents comes from the general fund where we were short. In fact, when I became governor, we were short $2 billion. I inherited the largest ever budget deficit in the state's history. So it's critically important in terms of making sure people have a higher quality of life and better health outcomes. But it's also important to the state of Louisiana in terms of our budget stability and the savings that we've been able to get from Medicaid expansion. And finally, with the $1.85 billion that we bring back from the federal government every year, that money gets invested in every community across the state. It's responsible for 19,000 jobs and another $100 million in general fund revenue because of the sales tax and the income tax associated with that economic activity. And that's all by a report with Dr. Richardson of LSU, a noted economist here in Louisiana. So it's exactly the right thing to do for the state of Louisiana. It helps families because people get to remain productive, they get to remain employed, the quality of life is enhanced because of Medicaid expansion. And obviously, if you have a child living in one of these homes, then that child is benefited as well. So it's critically important for our state. It's something I'm very proud of. And like I said, the day that I announced Medicaid expansion on my first full day in office, the easiest big decision I'll ever make as governor of the state of Louisiana.
The organization is the Louisiana Center for Health Equity, and we are a statewide nonprofit organization based in Baton Rouge, but we are working to address health equity across the state of Louisiana, or to eliminate or reduce the health disparities that we see in our state, which are formidable and which are very important to Louisiana becoming a healthier state. This is our 4th Health Summit in partnership with the Louisiana Department of Health, Office of Public Health, and the Pennington Biomedical Research Center. We are here today to talk about the disparities that we see in educational outcomes, in employment outcomes, wages, in healthy living across the board. And so we're talking about how do we become a healthier state and address the looming issues that face our children and families. Today the focus is really on children and families and how to support children and families through policies and initiatives that will make them or assist them in becoming healthier. It's such an honor to be here and to be standing before you, and I want to thank everybody for joining us. On behalf of the Louisiana Center for Health Equity, the Louisiana Department of Health, Office of Public Health, and our host, Pennington Biomedical Research Center, it is my pleasure to greet you this morning. Thank you for joining us at the 2019 Health Summit. Our theme today, as you've already heard, is working together for Louisiana families.
I serve as the chair of the Select Committee on Women and Children, which was created to study and make recommendations on issues regarding women and children, including advancing their well-being, particularly concerning health care access, promoting equity in education, economic advancement, health, criminal justice, and reviewing state laws to ensure inclusiveness for the concerns of the women and children. Additionally, I am the Vice Chair of the Senate Health and Welfare Committee. In my leadership roles in these committees and others, I have gained a great perspective about the state healthcare system and what is needed. As a policymaker, we are tasked with creating and changing laws to eliminate disparities and to move towards improving outcomes for the residents of our state. We rely on organizations and community partners such as LCHE to help identify gaps in healthcare services and develop solutions that will impact future generations. Like all of us gathered here today, I love this state, I love its people. And it greatly saddens me to realize that we have a great healthcare professional shortage, which in turn means nearly half of our residents are living in areas where there's lack of access to primary care, dental care, mental health care, and are stifled because of the lack of providers. Access to health care is a human right. I'm going to say that again. Access to health care is a human right. I have filed several pieces of legislation regarding health care. One of them happens to be Senate Bill 169. This bill will ensure that public health units, Louisiana Department of Health, establish a immunization registry for the purpose of improving immunization rates for children and young adults across our state. Also, I filed Senate Bill 219, which will require insurance policy to adhere to the standards that were set in place by the ACA by ensuring that certain parts of that stay in place if, unfortunately, it is repealed from on a federal level, which includes the eligibility for young people to stay on insurance until the age of 26, also ensuring that health insurance cannot insure people for pre-existing conditions or exclusions or limitations on annual or lifetime benefits. I think this is very important, and it's been stated that 90% of the people believe that those components of the ACA should stay in place.
We have a number of innovative research studies that extend into areas where you work, where you play, where you learn. Some of these include diabetes prevention and physical activity programs that are conducted at YMCAs and churches. We're training school cafeteria workers to cook healthy breakfasts and lunches for their students. We're testing innovative weight management programs in primary care clinics across the state. We're working on the best way to feed soldiers and improve their health, nutrition, and well-being. And we recruit diverse populations across all income groups to participate in unique clinical trials, the results of which will provide new knowledge and that translates directly into improving the health care that is delivered in your physician's office. And let me give you just a few examples of projects that might actually be in progress in your community today. We have Dr. Amanda Stiano, who serves on the Health Summit Steering Committee, and she's leading a project known as Team Up, a child obesity study. The program is designed to train pediatricians, nurses, behavioral health coaches in primary care clinics across the state in order to deliver evidence-based weight management strategies for families who want to get to a healthy weight. She's working with several clinics that specifically serve families insured by Medicaid. Dr. Peter Kaczmarzyk is leading a similar study for adult weight management in 18 clinics across the state, including several federally qualified health centers. Dr. Robert Newton is delving into the question of how to keep your brains healthy, something that we all are concerned about. And he's working on a project known as Rate and Pace. He's examining how exercise and some common medications may help to reduce Alzheimer's disease rates in the African American population. Stephanie Broyles has worked alongside Dr. Newton in another area, the study of how communities and environments impact disease. So she's working in neighborhoods and parks to shape our disease risks and health outcomes. She's working to encourage safe outdoor play areas for children to study and studying how to use mobile phone apps to help parents keep their children healthy. And this and many other programs, our faculty are breaking new ground in reducing health disparities in our communities.
Today, I'm going to talk a little bit about the initiatives related to our coordinated system of care, behavioral health for children with behavior support needs, as well as some of the early intervention and developmental disability services that we have put in place. But in addition to that, I'm going to talk a little bit about the expansion and the difference that it makes for women with breast cancer as far as their treatment, not just treatment, but in their initial diagnosis and screening, as well as for men and colon cancer and so forth. The signature event for the department and Dr. Gee and the governor has been the implementation of the Medicaid expansion. It was a significant promise from the governor, and it's a pledge that he did keep when he took over the office. What she did not share was that the expansion has meant an infusion of $1.85 billion in federal funds into our state economy, $3.5 billion of economic activity, and 19,000 jobs are the result of the Medicaid expansion. In addition to all of the health care improvements that Aaron mentioned earlier, we are now seeing increase in breast screening for women who are coming in who did not have health care, as well as colonoscopies for men who were in need of those services. We are seeing preventive care in the ways of diabetes and high blood pressure. These are, when we talk about 500,000 people who are now getting these services, many folks say that's a lot of people and that's a lot of dollars that are associated with that initiative, and I would agree. However, imagine those people, 500,000 people, not having access to preventative care. How about the thought of family members who have diagnoses of cancer? I've had the unfortunate event of having both my mother and father to be diagnosed in late-stage lung cancer, and we know that these things could have been diagnosed at an earlier stage, and preventive care would make a tremendous amount of difference. So we cannot put a value on what it would take to see improvements in diagnosis, in early diagnosis. And so when we think about this here as a state and we think about the cost, Louisiana is one of the 4th poorest states in the country. And so we should expect that Medicaid expansion would mean an increase in numbers, that there would be a cost associated with that when we consider, though, the cost with preventive care and early diagnosis compared to late costs that would be assumed when individuals come to emergency rooms or in stage 4 cancer, as my parents were. So we see this as a great advance for the state. Real quickly, I want to talk about the Office of Public Health. Some of the programmatic initiatives that we have seen is we've just recently received accreditation by our Office of Public Health. That means that we are only of 300, there are only 300 accredited public health entities in the country out of 3,000, so only 10%. So I'd like to say a quick appreciation to Dr. Bu and his team. What that means is that we have put forward great efforts to assure the health and safety of the public. We have evidence-based practice. That means that we're running in an efficient and an effective way, and that's important because the Office of Public Health, they play a major role in all 4.6 million lives of people in Louisiana, from the water that we drink to the food that we eat. We see the value in that, all even going to things as simple as barbershops and so forth. These folks play a great value to the state, and so we're so excited about that accreditation. We have some changes in we have the transformation of our public health units for the Office of Public Health with the advances made in Medicaid expansion and the growth of FQHCs. There are many activities that take place in our public health units that are no longer needed. We can transfer some of those responsibilities to other organizations, and while doing that, we can focus on some of the social determinants that Aaron spoke about. We can put our community health workers in place to support individuals with access to transportation, access to housing, housing and food and so forth. As she said earlier, 80% of the health outcomes that we see do not take place, or the successful gains do not take place through managed care. They do not take place in doctor's offices, but having access to those appropriate social determinants. I'll leave you with this. There's a baseball player, and his name is Mike Trout. Mike Trout has just signed the largest contract in professional sports history, the largest contract in professional sports history of about $435 million. $435 million. As a society, if we can afford to pay a baseball player $435 million, I believe that we can, as a society, invest in the health care of our most vulnerable population. And for time's sake, I'm not going to go through the numbers, but this gentleman makes 30,000 times more than a direct support worker that we have hired to serve persons with developmental disabilities and aging. And so I'm going to leave you with a quote that I have here from a famous actor. You probably won't know who it comes from, but I'll tell you at the end. He says, "Let us be the ones who say we do not accept that a child dies every 3 seconds simply because he does not have the drugs you and I have. Let us be the ones to say we're not satisfied that your place of birth determines your right for life. Let us be outraged. Let us be loud. Let us be bold." The actor is Brad Pitt. Thank you.
It takes a village to raise a child, and sometimes the village in Louisiana is failing our most vulnerable citizens. I think that it's wonderful to have the opportunity to come together, multidisciplinaries, all different kinds of backgrounds and philosophies in this room, to talk about what are the best ways to take care of our children and families, and what are the best ways to address the health and well-being of those vulnerable citizens in our society. I am a huge LSU baseball fan, not so much on the pro side, and with that statistic, I am just totally blown away. I can't imagine what the Department of Children and Families, or the Department of Health, or Education, or Wildlife and Fisheries, what any of our departments could do with that kind of money. That is just an incredible thing for me to even think about. DCFS serves 1 in 4 Louisianians. Think about that. The Department of Children and Family Services serves 1 in 4 of our people. And that is because we have such a high rate of poverty in this state. The department runs the SNAP program, the food stamp program, and we have over 800, there are about 800,000 people that get food from the government because they cannot afford food without this supplemental program. And it is a supplemental program. It does not cover you for the whole month. And by about the 3rd week of the month, we've got families across this state that don't have enough money to put food on the table for their children, and so they rely on food pantries and churches to fill the gap. We can do better than that. Thank you. We also run the program for child support enforcement, and that is one of the best anti-poverty programs that we never talk about, because when a non-custodial parent doesn't pay for their children, what happens to the most often the mom, who is left behind to try to make up the difference? That's hard. And we have an awful lot of families in this state that, because of the efforts of the department, we get that child support, we help the enforcement, and we get that money back into the hands of the children that deserve the very best from both their parents, regardless of which one they reside with. And so as we do that work, we have really dedicated people that feel like they're making a difference every day in those families' lives. And it may not seem like a real exciting or challenging job to do eligibility determination, but we have our food stamp workers that really sit at the phone and counsel people and help people and deal with parents in crisis and in tears, saying, how am I going to feed my family? So these workers are challenged to be coaches and advisors and counselors and listeners to vulnerable people trying to figure out how to be healthy and well in a society that does not honor them and support them in the way that it should. I really think that we have got to address this drug crisis that's affecting our state. It's affecting our babies in utero. It's affecting our children as they're being raised in drug situations. It's affecting the mental health. It's affecting the social fabric of our society. So I'd really like to see a greater awareness of the dangers of drugs and a greater understanding of what's happening to the people that are using drugs, and a much greater funding for people that need substance abuse treatment.
Medicaid plays a really important role, not only in the health of children, but also in their success in school and in life. We can spend billions, trillions of dollars on health care, and if we don't start to address the underlying causes of health, then we're just going to keep spending money, money, money. We keep talking about bending the cost curve, right? But what we're doing is focusing on people who have multiple chronic health conditions rather than making sure that people don't develop those health conditions to begin with. So you guys have heard this for years. I think this is like going on 30 years now. The United States spends 50% more than any other industrialized nation on health care, okay? Well, geez, why aren't we getting the health outcomes from that? We should be doing 50% better, and yet our longevity is not as long as other countries. We've already talked about how our maternal and infant mortality rates are higher than other countries. And the reason for this is that healthcare is really only a small part of it all. You've seen in this pie chart, you've seen this different ways, different sources slice the pie up a little bit differently. But generally, healthcare or clinical care is only 10 or 15% of what contributes to overall health. And behaviors and social and economic factors are the bigger contributors to health. So, one of the things I usually say at this point in time is that part of the problem we have as social determinants is that we're not focused on children. We are focused on saving money today, tomorrow, next month, not 20 years down the road, right? It's a short-sighted approach. And so the reason I focus on kids is that we don't see a lot of work going on social determinants on kids, even though kids make up half of Medicaid enrollees. Of all the enrollees in Medicaid, half of them are kids. Kids are the lowest cost. These are Louisiana dollars. You spend 10% on a child that you spend on an adult who is a dual eligible, who's on Medicare and needs nursing home care, and that's because they're poor, right? We've got to break that cycle there. So most of the efforts are focused on high-cost populations, but we do know that the knowledge that we have about social determinants is really driving change in how Medicaid is delivered, more to value-based purchasing and population health. But there's some real issues when it comes to kids in this regard. There are minimal savings, as I've mentioned. Kids who have high cost needs are very complex. If an adult has diabetes, an adult has diabetes. Kids with multiple disabilities have a whole range of issues, and that one child doesn't look like the next child. So that complexity doesn't lead itself to sort of focusing on a particular disease. The fact that this is out of the hands of doctors. Doctors can't feed the child good food or make sure they're in safe housing. So there are lots of barriers both to addressing social determinants and doing value-based coverage. But really, going back to this whole issue of ACEs, this is all about social determinants. It is poverty and substance use and mental health and violence, abuse, or neglect, divorce, and death of a parent. All of these things create adverse experiences for children. And if we were there providing supports to those families and making sure those kids had adequate food, stable housing, were in safe environments, we would be able to offset some of the bad experiences that happen. So here's the clincher. We spend 50% more in the United States on health care. However, if you look at a combination of health care and spending on social supports, housing, food, transportation, guess what? The United States doesn't even rank in the top 10. We don't even rank in the top 10. There's a book called The Great American Paradox, Why Spending More is Getting Less. And it's by two researchers, one at Harvard and another one somewhere else, I can't remember. But they basically looked at the spending on social services in these countries compared to health care. But look at the size of those golden bars compared to health care. Those countries are spending 2 and 3 times as much money on social supports as they are on health care. So no wonder they're getting better results. So we really have to break the cycle. We have to start focusing preconception on birth outcomes, making sure that babies then are in environments that support their success in school so that we can stop filling up this pipeline with adults who have these multiple chronic conditions that continue to eat up our health care dollars. And just a word about improving health equity before I wrap up here. This is what we really know to be the issues that we have to spend more resources on. We obviously have a lack of provider capacity. We in particular need more mental health providers for children. People talk about mental health services for young children and everybody goes, what? What are you talking about? But we need it. We need it. It's a problem. And we also need not only to get more capacity, but to expand the capacity that we have. We can do that through things like telehealth. And Mark mentioned this, making sure services are culturally and linguistically appropriate, integrating physical and behavioral health, which you have done, aligning those financial incentives so that managed care companies are focused on the priorities that you set, and not necessarily looking short term, and then tackling those social determinants. And I just wanted to give you an example of one state that is making some headway on health disparities, and it's called Rhode Island, and they've named it their health equity zones. And what they have done is they are braiding funding from all kinds of sources. They have one person who is in charge of tracking all these grant funds that come in through TANF or SNAP or the Child and Maternal Health Block Grant and Medicaid. And they're breaking down silos across agencies, realigning staff that are focused on outcomes, promoting that cross-sector collaboration. They're moving from disease-focused, like we're going to go in and take care of diabetes everywhere, and being community-focused. And they allow communities to define for themselves what it is that is going to have the best shot at improving the health and well-being of their residents. And that's across a broad range of things, including birth outcomes and improving the social determinants. So again, a link there, but I would encourage you to take a look at that because it's very community driven, and it sounds like the community partnerships that are being launched here may indeed might be an idea to try in one of those models. So let me just close with a call to action, and that is advocacy matters, right? Tell me. Advocacy matters, right? First of all, there needs to be a stronger alignment between public health, your Medicaid agency, and your agency for children and families. They can't operate in silos. You need to maximize Medicaid reimbursement. Right now, you get $1.86 in federal funds for every dollar you spend. Next year, that grows to $2.02. So it's a great return on investment. So you need to join with the child healthcare community, with the child, with education, with business, because business cares about having, kids come out of school and be ready for jobs, to really look across these sectors in order to make the case for more investment in children, recognizing that return on investment is going to be longer term, but if we improve school attendance and performance, if we lower special education costs, if we reduce involvement with child welfare in juvenile justice systems, and if we grow a healthier adult population, then that's when we're really going to see health outcomes be what we know they can be. Thank you. Medicaid expansion has had a huge impact on Louisiana. First, it's been an investment in the Louisiana economy, creating jobs and economic activity. But second of all, the rate of uninsured parents in Louisiana has been cut in half, from 22% to 11%. And when parents have health coverage, they're healthier and better able to take care of their families. Their children are more likely to get health care. The family is more financially secure, and there's less stress in the family so that they do better all together.
I'll start with just talking about something that's true in East Baton Rouge Parish, true in every parish in the state, true in every community in this nation, that poverty and income and wealth are not equally distributed across our communities. That is to say, if I look at any one of these zip codes, it's not that I have the same distribution of incomes across all of them, but rather we concentrate poverty, we concentrate wealth in various different areas. And here you can see the zip codes, especially right around the bends in the Mississippi River, 70807, 70805, 70802, have the highest levels of poverty. Now, another truth that's found in East Baton Rouge, that's found throughout the state, and that again is found throughout the nation, is that when we look at areas of industrial activity, those often overlap quite closely with areas of poverty. Now, again, this is correlation, not necessarily causation. One could imagine there's a number of reasons for this. As I noted, those communities are near the bend in the Mississippi River, so it could be that you want industry near access to modes of transportation. It could also be that industry, those areas where there is a lot of industry and potentially related pollutants in the air drive down housing prices. So it sort of draws people in who don't have quite as much money to spend on housing. It's also true, and we know this for a fact, that the way that we zone also can force these kinds of situations where people who live in poverty also live next to heavy industry. So that's an interesting correlation, but then what does that potentially also link to? So this next graph shows you ED utilization. So that's emergency department utilization for asthma amongst children, again, across the entire parish. I'm sorry, and what you see here is that the highest rates of asthma or ED utilization for asthma is sort of a proxy for how bad is your asthma being managed, or how severe is your asthma. Correlates very nicely with the areas of poverty, with the areas of industrial processing. Now, asthma, as I'm sure many of you know, this is a disease of really reactive airways. So what you have is a lung that when it sees an irritant, the small airways can clamp down and make it very difficult for you to breathe. You could have the same individual with the same lungs living in 2 different zip codes, and we would expect that their disease severity is going to be different because of their exposure to environmental toxins. So there's definitely, if we go back to that graph, a difference in components of genetic makeup. Maybe there could be more genetic predisposition to asthma in those areas that I've shown in the darker color. But even with that genetic predisposition, you need a trigger with asthma to really see that disease manifest itself. And what we're seeing is that it's most manifest in this area, again, of low income and increased industrial activity. What I think is interesting, and to take it back to where we were starting this morning with Medicaid, is that the statement was made that Medicaid is a huge boost to income, that Medicaid serves a really critical role in protecting people who have health conditions from the devastating financial consequences of their health conditions. What I think that this map, however, shows is that health care coverage in and of itself is not protective of these other insults that people can have to their health. It does not necessarily protect you from having the development of chronic conditions even in childhood. There is so much more that has to go into the nature of that health care, but also, again, all of these social determinants to actually make good on that increased access to care. And so here you see that the areas with the lowest level of healthcare access, the lowest levels of insurance, actually don't really correlate with the areas where we saw that there was really tremendously high asthma-related ED utilization. So my purpose in sharing all of that is one, because Ms. Stewart said she wanted us to talk to you about the recent findings, but two, again, because I think this relatively fresh data really sort of drives home this story about how environmental factors, social determinants can drive health. Health also can impact education. So health can impact a social determinant if we sort of frame it from a health standpoint. Asthma is a really critically important one, actually, as it turns out. 1 in 10 children in the nation, and in certain communities it's much higher than 1 in 10, have asthma conditions, and it is the leading cause of school absences. More than 36,000 children miss school each day across the country as a result of asthma, and that's concentrated specifically or especially in low-income and minority populations. And again, that correlates with what we saw in East Baton Rouge, even taking outside the industrial exposure. Why should that matter? Well, chronic absenteeism has a huge impact on engagement in education, retention in education, and the outcomes that we look for, the key milestones that all of us want for our children in really actualizing their education. So we see low rates of reading at the 3rd grade, we see lower rates of graduation, and we see people, low rates of completion of college. So if you look at the sophomore year, we see 22% lower rates of completion of college degrees. For children who had chronic absenteeism growing up. So being unhealthy as a child, being in environments that make you sick, directly impact your ability to engage in really your job as a child, which is learning and growing. And being able to be on that virtuous cycle that you saw in Ms. Brooks' talk of then getting a job and then being a contributing member of society. You don't have a chance if you're too ill to participate in your education in the first place, regardless of whether you have health insurance coverage as well. Now, the converse is true as well, and that's where I'm going to focus a little bit more of my time, which is that education is a clear determinant of health. So just as important as it is for us to be healthy enough to go to school, we have to go to school because we know that as we look at, especially going into adolescents and adults, low educational attainment has a significant impact on health. And we shouldn't allow these social determinants to really stand as they are and impact our health negatively. It's not a tenable situation. My message today was that health impacts education and education impacts health. We really need to be investing in children across all of these areas in order for us to have healthy, productive childhoods that lead to healthy, productive adults.
What needs to happen in Louisiana?
Well, we need to make sure that we're keeping children healthy so that they actually can get to school. We need to ensure that our kids who are most vulnerable are getting the medical care and the preventive care that they need so that they can focus in class and really be on the great start for adulthood.
We know that in order for our students to do well academically, they have to be healthy, they have to have the supports and the support structures at home that they need in order to be successful when they arrive at school. So partnering with these professionals and these experts in the areas of health, behavioral interventions, mental health is so important to making sure that we can support our children.
Just for some context, in August of 2018, the state of Louisiana put out a maternal mortality report covering 2011 to 2016, and it revealed some really troubling things about maternal death in Louisiana. And the first thing it revealed was that maternal death is on the rise. It is far higher than the national average. And what it also revealed is that we weren't doing a very good job of measuring maternal death. You can see in 2011 and 2012, maternal deaths were a little bit closer to the national average, and efforts began in 2012 to do a much better job of more accurately measuring the scope of maternal mortality in Louisiana. And so as you can see, as the numbers climbed, we got a much clearer picture of how severe the maternal mortality problem is in Louisiana. The second thing the report revealed, and for me the most troubling, was that for every one white woman that dies in Louisiana, 4 black women die. The report also talked a lot about preventability. It looked at the causes of these maternal deaths and tried to determine for each one whether or not that death was preventable. And it really revealed 2 really interesting things. The first is that the 2 leading causes of maternal death in Louisiana are hemorrhage and hypertension, preeclampsia, and associated cardiomyopathy. And the other thing it revealed was that 50% of those deaths, so 50% of the deaths related to hemorrhage and hypertension, cardiomyopathy, were preventable. So that meant that there was at least some chance that an intervention on the part of a healthcare provider, a health system, a friend, a family member, a community, some aspect of the system that surrounded that woman failed her, right? That death could have been prevented.
Why do we pick prematurity as our priority? Well, I'm glad you asked. So 4 million babies are born each year. Out of that number, 380,000 are born preterm. That's 1 in every 10. So prematurity is just birth that occurs before 37 weeks gestation. So babies who are born premature have a higher chance when they live in a racial or ethnic background like African Americans, Native Americans, Hispanic Islanders. Communities of color are more likely to be born premature than their white counterparts, as well as zip code barriers as well. Many women don't get the evidence-based care they need that would in turn prevent them from having a premature birth. And it costs $26 billion extra dollars in healthcare costs, which is really important because it is a business. So remember that reducing prematurity also reduces the costs for healthcare, for businesses and corporations as well. So each year, March Dimes publishes a national preterm report card. So the card groups preterm birth rates by states and by grade. So rates range from a letter A, which is about 8.1, to an F, which is about 11.5 or higher. The majority of states have a C through F grades, and you'll see from the color-coded map which states fall into what ranges. Right now, most states are falling into that C through F range currently. The United States grade for 2018 was a letter grade of a C, which is 9.9. So taking it to a local front, the Louisiana preterm birth rate has been at the bottom range along with other Gulf Coast states for about 10 years now. So you'll see that we've ranged from 13.0 starting in 2007, and it's high at its highest, and its lowest was 12.3. Now we're about 12.7, which is kind of mid to higher upper range for us. But keep in mind that it takes many, many years for a state to drastically change its grade due to multivariate measures that prematurity involves. It's not one cause, it's not one simple solution, so it takes a whole lot to actually have these numbers go up or down in any drastic format, okay? So any decrease is actually great improvement for any state.
presenting the Healthy Start program as a model for eliminating these racial and ethnic disparities. Healthy Start Initiative, as it was called, when it first started in 1991, the country was still responding from the alarming infant mortality rates that we've been seeing since the 1980s for babies in America dying before their first birthday. And then when you really dig deeper and begin to look at the racial ethnic breakdown of that, you saw that black babies were doing worse than anyone's babies. And so someone had the bright idea, we need a different approach, we need some innovation, which is what we're talking about here as well today. And so they decided to try this program as a demonstration program, and Thurman McCann, who was a doctor at Mercer at the time, her and her team came up with this idea of engaging the people impacted by the problem to see if that would make a difference in improving rates of infant mortality. And it did. After those first 5 years of demonstration, they replicated the program, and again in 1991 it began with 15 programs, and with the help of the March of Dimes we added 6 other programs to that initial 15, and today we have 100 programs across the country. That was a test. And I think telling the story of the Healthy Start Initiative is a community-driven approach to address infant mortality reduction. And that's the simple name of the program, but it told you everything. It told you what the problem was, infant mortality. It told you who's going to address it, the community. And then also it told you what we want to do, and that is to eliminate infant mortality, and then also what we want to do. And the strategy was to use a community-driven approach. And so I think that's important to remember about the story. Again, there are 100 programs around the country, and just less than 2 weeks ago, we were awarded our next 5-year funding. So those 100 sites were refunded to address racial and ethnic disparities in birth outcomes, and also some received an additional grant to enhance clinical service to address maternal mortality. Hugely successful. I'll talk about the federal Healthy Start programs, and there's 100 programs around the country. It started in 1991 with just 15 programs, but the plan of that program was to engage community residents in the solutions for their health. And so that's a great example of engaging people impacted by a problem, and the problem definitely has gotten better. So we have seen a decrease in infant mortality, although the disparities remain, but it's hopeful in addressing because people are fully engaged in the process.
People who had experienced adversities in their childhood before 18 years of age, actually you could see chronic long-term effects on their health. And as health, but all those mental health, behavioral, not just physical health. So what we've learned now over these almost 20 years is we're educating people about ACEs across the country. Louisiana is the 7th state in the country to actually adopt the ACE Educator program. It was done as a combination, as a partnership between DOH and the Tulane School of Public Health. And from that, we are seeing more and more people actually say, okay, adverse child experiences, once you have one, you can't really get rid of it. So how do we recognize it? How do we resource for the kids? And then how do we look at our adult population and say, well, maybe your issues of mental health illness. Maybe that's not just something that's happened to you in the last few months. Maybe there's something that's a deeper root. Heart disease, obesity, infant mortality. It encompasses almost every entity.
My presentation today dealt with primarily looking at kids from a behavioral health lens, and that includes kids in school, kids in child welfare, kids in the juvenile justice system, that these are all the same kids. They have all in common, they have behavioral health problems, they have trauma backgrounds that all affects where they are in the system, including school systems, juvenile justice, child welfare systems. So looking at the kids from a standpoint of they have behavioral health needs that are impacting their outcomes in life, and to put a priority on addressing those behavioral health needs to change some of the outcomes that we can anticipate. Some of the poorer outcomes, including kids ending up in jail, kids ending up in foster care, kids ending up dropping out of school.
My presentation dealt with services that are available, behavioral health services that are available in schools and in communities. So some of the information was about increased access to behavioral health services in the school setting, increase evidence-based practices, and also services that are available outside of the school setting.
My presentation today dealt with the activities in the Department of Education related to the whole school, whole child, whole community model and addressing behavioral health concerns in schools.
My name is Precious Barber, and I'm from Natchitoches, Louisiana. I didn't have Medicaid or any type of health coverage for 14 years. So just think about it. If I got sick, everything had to be at the emergency room. I call those the Band-Aid units. So just think about that. No coverage for 14 years. And then I heard about Miss Alma and them doing Medicaid expansion, not really knowing what it was, but I started going to Baton Rouge and helping to fight for the cause. I created the change that I wanted to see. I didn't wait on anyone. Mm-hmm. And when it passed in 2016, I was one of the voices that stood there and cheered it on. Now I'm able to go to the doctor and receive the proper health care. For instance, some of you, if you want a trainer, you might have to pay for your trainer, but under Medicaid, I'm able to get a free trainer so that I can have a healthy lifestyle. And I'm very grateful for that. But also, I would like to let you know that even though we're doing such great things in Medicaid, we also have our cons. And those cons is that we need better transportation providers, better doctors for those who are in poverty. And also, because you are the policy makers, I'm just a civilian. I like to call myself the Medicaid spy. I go find out everything and bring it back to y'all. I want you to think about when you start making your decisions about Medicaid, Medicare, I want you to look for Pookie, Keisha, Toya, and bring them to your meetings. Bring those who are in poverty to your meetings so that we can help you to make those decisions. How do you know what we need if you're not even on Medicaid yourself? We need y'all to do that. We need to know that our voice is heard. Because if we have a voice in these meetings, then when you make your decision, I promise you, we won't be 50th in the state anymore. When you get a people that's backing you, who can fight against that? Whether you believe it's a myth or truth. Can I give you an example? The Bible said that they wanted to stone Jesus and kill him. But they say they couldn't kill him because of the people. Whether you believe it's a myth or a story, it's the people that can carry this program. But you have to let us know that we are heard and we will fight to the death for you. Thank you. And that is my testimony. I was able to go to a doctor. Before that, I was mostly just going to the emergency room because I had no health care for 14 years. And now I'm able to get treatment for things that I need, all type of things, and I'm just grateful for health care.
How has your health been now since you're able to get medical coverage?
Well, my health has been better, and it's getting better. Because of Medicaid, I'm now able to get a trainer for free that can help me with weight loss.
It's a pleasure to be here today. I was asked to appear, and here I am. Prior to mine, I am a former incarcerated person. Prior to my incarceration, I worked for 29 years as a litigation paralegal. Worked in some of the top law firms in the city, specializing in bankruptcy and corporate matters. I was incarcerated 2010 for a nonviolent offense, discharged 2017. After I discharged, there was not a lot of information available for those exiting prison with regards to how you get your services for Medicaid, any other services, any social services that you may be available to have. I want to say maybe 2 or 3 days after I began to call on Ms. Smith, I began to call on James Wyndham for some advice and how to get going and how to, once I began to get myself acclimated back into the system, how I can help the next person. As a result of that, I am now executive director of my reentry program, JCLFS, in Jefferson Parish, Louisiana. Thank you all very much. It's been a pleasure to appear before y'all today. It's meant wonders. I'm not able to get, as a formerly incarcerated person, it enables me to get wellness exams and proper health screenings from my physician.
How do you feel now compared to when you had no medical insurance?
After I exited prison, there were not a lot of programs in place, but so you have to have the wherewithal to actually find those programs, and once you find those programs, then you begin to relate those programs that are available to other individuals.
Medicaid has helped me a whole lot. When at first I couldn't go to the doctor unless it was to the emergency room. Now I'm able to have a primary care provider. Just in November, I had a health scare. I was able to go to the doctor and get what I needed. I no longer have to wonder, how am I going to get to the doctor? What I'm going to do? Will I be able to pay for this? I already know that it's paid for. So that was my blessing, is that now I'm able to have my own doctor, and that's a blessing.
One of the things that I think is most important is to expand the collaboration that we have across state agencies. We know that we have the Department of Education, we have the Department of Health, we have Department of Labor, we have these different departments, but we want to see more collaboration across the various sectors in addressing the issues that face children and families and looking at it from the social determinants of health perspective, which is, how did we get here? What are the causes of the disparities in the first place, and how do we eliminate or remediate those causes?
There seems to be a great buzz around overall health care and making the investment. I'm so excited by the many different professionals that are here today, as well as the great initiatives that they are working on. So excited to learn about some of the great work that's taking place.
Today has been phenomenal. We have probably around 250 or so people in attendance here from various sectors, various disciplines, various professional groups and organizations. We have people here from the insurance companies, people here from the state government, from the governor's office, from the various departments, and also from research and providers. We have a huge audience here that's really working together. I was even told that we have one of our judges here, our juvenile judges here, and maybe there are even more. But we are happy to see all of these different sectors and disciplines and individuals come together to really have a conversation about how we move forward to improve health outcomes for children and families in the state of Louisiana.
If people have questions like more information, what should they do?
People can contact us through our website, which is www.lahealthequity, or they can contact us through Facebook, which is our Facebook, which is the Louisiana Center for Health Equity as well. The best way to contact us probably is through our website, through the Contact Us page on our website. Again, that's www.lahealthequity.org.